Yes.
Yes, yes.
Okay, good evening and a very warm welcome to you all. And we have a very special guest today, our Honorable President, National President, Dr. Jayalal sir with us. And as we all know, COVID-19 phase persisted for more than a year. We are now accustomed to a new normal, social distancing, mask, sanitization. But still, we have a lot of confusion about drugs being used for treatment, which drug to be used at which stage, and a lot of unanswered questions regarding vaccination also in our mind. Its impact on fertility, pregnancy, fetus, menstruation, lactation, and also how to identify on time which case will progress. Do we need to be careful? Is there any chance of reinfection with good amount of antibodies in our mind, in our body? We need to update ourselves in all these areas. Now, before inviting the chief guest, our honorable President, National IMA, Dr. Jayalal, to inaugurate the webinar, I take this privilege to introduce our esteemed chief guest to you all. We welcome our National President, IMA, Dr. J.A. Jayalal, sir, and just few lines of introduction of sir. Professor J.A. Jayalal sir is the National President, Indian Medical Association. He is the National Head, IMA UNESCO Bioethics Chair. He is MS, FRCS Glasgow, DIS, FASES, MBA, and PhD also in surgery. He is a very eminent laparoscopic surgeon and professor of surgery, Kanyakumari Medical College Hospital, Asari Pallam. So we all welcome you, sir. So this is a virtual bouquet of flowers for you, sir. Please accept. And I request you, sir, please address the gathering of ophthalmologists, young ophthalmologists, and all the women doctors of Jharkhand. Over
Thank
to you,
you.
sir.
Yeah, thank you very much, Bharti Kashyap. Beloved and distinguished President of IMA Jharkhand, my good friend Dr. Arun Kumar Singh, the Women Doctors Wing National Chairman Dr. Isoda, Secretary Dr. Kavida, the organizing chairman and the very dynamic, enthusiastic entrepreneur and very sincere working a doctor of our Jharkhand and the national doctor, Dr. Bharti Kashyap, a person who has been awarded by the government of India, the the president of India, and very dynamic work who is doing on the cervical cancer, and other distinguished members of IMA Jharkhand, the Ophthalmology Association of India, and also the Women Brigadiers of Indian Medical Association. I'm extremely happy and delighted to note on the pretext of WDW and also Ophthalmic Association of Ophthalmic Doctors, Dr. Bharti Kashyap is able to organize this wonderful seminar to dispel the myths on the COVID management and give a correct picture on how to go ahead on the COVID appropriate management and behaviors in this country. Friends, we all in a very critical position on behalf because of this COVID pandemic. The people are struggling hard to find the beds in the hospitals, ICUs, oxygen shortage, remdesivir shortage. More than that, now we are going to across the situation of the manpower shortage, which is prevailing in this country now. The doctors who are working in this country in the COVID wards are stretched beyond the level. They are working beyond their capacity. Many of them are getting burned out, and we are in a very pitiable situation. I am very sorry to report to you, in the last 25 days, we have lost 72 of our doctors, which we have never seen in the second wave, first wave. The second wave is very lethal, not only to the country, but also to our medical fraternity. And many doctors of our young age, 50 to 60, has lost their life in the battle of the COVID. And many of our doctors are in the still getting and getting treatment, including many of our leaders in the hospitals to recouping from this corona pandemic. I just want to tell this because I appeal to all my colleagues, all my members of Indian Medical Association and the young brigadiers and the women brigadiers. Please take care of your health and be very sure, be confident on the way in which you are moving around and the way in which you are taking the COVID appropriate behaviors. That is the most important thing. And I'm so happy Dr. Bharti Kashyap is able to organize this meeting where I just gone through the lectures. There are wonderful topics you are going to take. How you are going to make the financial management problem, how you are going to make a single clinic, how to cope with the issues, and the protocol management which she is doing. And I was told by one of the very big entrepreneur doctor, living for a year is the most important than thinking too much on the financial management. But that is not absolutely true. Even when it is a financial management is a very important thing at this great moment, and we need to plan. We need to tell the ways in which that we need to can go ahead. Probably it is not an advisable time for invest heavily, but definitely it is needed hour for managing because as a for a doctor, it is not only finance for yourself, but for the people who are depending upon you, the staff who are depending upon you. You need to take care of them also. So it is a big challenge. I'm extremely delighted you are organizing this program. I mean, Dr. Bharti Kashyap is very meticulous, very sincerely she is doing this program. I wholeheartedly congratulate her on behalf of the Women Doctors Wing. I'm so happy Women Doctors Wing is rising to the occasion and doing a good job. Keep it up. My hearty congratulations to Dr. Arun Kumar Singh sir, also very veteran leader of Jharkhand and who is spearing ahead the IMA activities. I'm looking forward to hear a lot from you, and I'm sure that you all people will be working hard to see to that our country is safely passing through that vaccination and the COVID appropriate behaviors and safeguarding ourselves is the big challenge in front of us. I wish all the best for this program and looking forward that this will give and empower our practitioners to know the nuances of the medical practice and the clinical practice, and they will be get equipped with to face and whatever challenge you are going to face. Thank you very much. Once again, I congratulate you all.
Thank you, sir. Thank you, sir. So now, before we start with the first international speaker, I'm going to introduce the special invitees, apart from our respected national president and the discussants from Women Doctors Wing IMA Jharkhand, as well as my co-moderator, Dr. Vibhuti Bhushan, who is Secretary, Jharkhand Ophthalmological Society. So our first, our special invitee is Dr. L. Yashoda. We welcome you, madam. So please accept our virtual bouquet of flowers. And madam, are you there?
Yeah, I'm there.
So madam has 30 years of experience in general practice in Tamil Nadu. She has worked IMA local branch and state. She has got awards from national, state, and local branches. Please accept our welcome flowers, madam. Our next special invitee is Dr. Kavita Ravi. Madam, are you there? Dr. Kavita Ravi, madam?
I'm here.
Yeah. Okay. So, please accept our welcome flowers, madam.
Thank you.
She is additional professor of pathology, Government Medical College, Thiruvananthapuram. She is currently working as additional professor of pathology at Government Medical College, Thiruvananthapuram. She is the National Secretary, Women Doctors Wing, IMA. She is the joint convener, Medical Students Network, members of Academic Council and Planning, Kerala University of Health Sciences. Our another special invitee is Dr. Arun Singh sir. He is has retired as Chief Medical Officer, BCCL Coal India Limited, State President, IMA Jharkhand, President, Indian Association of Occupational Health, Coalfield Branch, Vice Chairperson, Indian Red Cross Society, Dhanbad, ex-President, Coal Mines Officers Association. We welcome you, sir. Please accept the flowers, sir. Sir, are you there?
Thank you.
Sir is always very inspiring to me. Very nice president we have. Dr. Pradeep Singh, sir. He's our IMA secretary since 2014. He's very active IMA secretary. He is 3 consecutive terms as vice president and Jharkhand State IMA. He's posted as chief medical officer, Legislative Assembly. Sir, Pradeep Singh, sir, are you there? He is busy with some of the relatives who is suffering from COVID. This is the welcome flowers for sir. Next invitee is Dr. Shambhu. Dr. Shambhu, are you there? He's not there. He's our IMA secretary. So now over to I have to introduce my co-moderator, Dr. Vibhuti Bhushan, who is always there with me. He's my classmate also in MBBS. And he's MS from RIU AMU Aligarh. He has been trained in retinal diseases, including ROP from Shankara Netralaya, Chennai. He's the director of Vishnu Netralaya, Jamshedpur, and a prominent eye surgeon from our state. He's the secretary of Jharkhand Ophthalmological Society, and myself as chairman scientific committee of Jharkhand Ophthalmological Society, and Dr. Vibhuti Bhushan as secretary are a team. And today also in this webinar, we both are co-moderating the entire session. So now I'm going to introduce the discussants from Women Doctors Wing, IMA Jharkhand. Dr. Beauty Banerjee, are you there? Dr. Beauty Banerjee, are you there? So she is the Vice President, Jharkhand Women Wing.
Yes, I am here.
Okay. So she is the Vice President, Jharkhand Women Doctors Wing. She is the executive member, KC Rai Memorial Hospital. Dr. Rashmi Prasad, are you there? She is the Vice President.
Yes, I am there.
Okay. She is the Vice President to Women Doctors Wing. She takes most active part in all the cervical campaigns in far-flung areas of Jharkhand, led by, she has gone with me to Santhal Parganas, far-flung areas, to so many far-flung areas of Palamu and so many areas. So Dr. Prabha Rani, she is Secretary, Women Doctors Wing, IMA Jharkhand. Dr. Prabha Rani, are you there? She is not there. Dr. Amita Ray, she is the Vice President, Giridih IMA. She is Chairperson, Miss Mission Pink Health Jharkhand. Dr. Amita Ray, welcome. Are you there, Dr. Amita Ray?
Yes.
She's not there. Dr. Nupur Chandan, she is the practicing gynecologist. She's president Dhanbad branch of Women Doctors Wing. We welcome her. Dr. Nupur Chandan, are you there? He's not there.
Yes, I am there.
Okay, welcome Dr. Nupur Chandan. Dr. Arpita Gandhi.
Unmute.
Please mute yourself. Please mute yourself. Dr. Shubha Rani, Secretary, Women Doctors Wing, Jamshedpur branch. She is the practicing gynecologist. Dr. Kiran Mala, she is President, Women Doctors Wing, Sahibganj branch. We have worked with her in more cervical cancer campaigns in Santhal Pargana. Dr. Soumya Jain, she is the Vice President, Women Doctors Wing, Ramgarh chapter. She owns a very big multi-speciality hospital. Dr. Anupam Singh is Secretary, Women Doctors Wing, IMA Ramgarh chapter. She is Joint Secretary, Women Doctors Wing, Jharkhand. Dr. Vandita is Joint Secretary, Women Doctors Wing, Ranchi chapter. I hope everybody has joined by now. Dr. Nisha Lalwani, are you there? She is a practicing physician and a gold medalist. Dr. Ranjana Modi, she is the executive member, Women Doctors Wing, IMA Jharkhand, and WDW Dumka chapter president. She is. Dr. Ruchi Bhushan is Secretary, Women Doctors Wing, Gumla chapter. We have made chapters in all over Jharkhand. So in every city, we have women doctors running. So Dr. Rita Chaudhary is President, Women Doctor Wing, Lohardaga chapter. Dr. Rita Chaudhary, are you there? Dr. Shraddha, are you there? I saw you. Dr. Shraddha, I saw her. She is the active young member, Kodarma chapter. Dr. Sanjukta Nanda, she is the treasurer, Women Doctors Wing, Jamshedpur chapter. Dr. Bharti Pushpam is very active. She did lot of eye camps with me in Sahibganj and the Rajmahal area of Santal Pargana, which is the very far-flung area of Jharkhand. She is Vice President, Women Doctors Wing, Sahibganj chapter. Dr. Khushbu Priya, she is very dynamic lady, again from gynecologist, again from Sahibganj, did a lot of work with me in Sahibganj area. She is Secretary, Sahibganj chapter. Dr. Sadhna Kumari is former Secretary, Dhanbad OBGY Gynae Society. She is now over to Dr. Vibhuti Bhushan for introduction of Jharkhand Ophthalmological Society panelists, discussants, and young ophthalmologists discussants also. Over to Dr. Vibhuti Bhushan.
Yeah, I welcome you all once again. And before I introduce the discussants of Jharkhand Ophthalmological Society, I would like to introduce our President and Chairman Scientific Secretary. I'll just share the screen. Yeah, is my screen visible? Can you see?
Yes, we can see.
Yeah, Dr. Lalit Jain is the President of Jharkhand Ophthalmological Society. And he's a very senior, very experienced ophthalmologist. He's a community ophthalmologist in private practice since last almost 35, 36 years. Then we have our very dynamic Chairman Scientific Committee, Dr. Bharti Kashyap. She is the first woman ophthalmologist of India who got awarded with Nari Shakti Puraskar by Honorable President of India. She is the National Vice Chairperson of Family Benefit Scheme Women Empowerment and Networking Committee. She is the Chairperson of Scientific Committee of Jharkhand Ophthalmological Society. She is Secretary Women Ophthalmologists Society Jharkhand Chapter. She is the Secretary of International Society of Manual Small Incision Cataract Surgeons Jharkhand Chapter. And she is also the Secretary of Ranchi Ophthalmic Forum. So now I'll give a brief introduction of the discussants from the Jharkhand Ophthalmological Society that we have. I'll just share the screen. Is it visible? Is my screen visible?
No, screen is not visible yet.
Is it visible now?
Yeah, that's okay.
We have Dr. Anand Thakur with us, who is the President-elect of Jharkhand Ophthalmological Society. He was the Managing Committee member of All India Ophthalmological Society representing Jhos. He is a Ranchi-based senior ophthalmologist with vast experience in cataract and glaucoma surgery. Dr. Sushil Bajoria is a very senior consultant and head of the Department of Ophthalmology, Tata Main Hospital in Jamshedpur. We have Dr. S.P. Jakhanwal, who is the Secretary and Superintendent of Jamshedpur Eye Hospital, one of the oldest hospitals in Jamshedpur. He is a senior consultant and HOD Department of Ophthalmology retired from Tata Main Hospital. Dr. Vandana Prasad, she is a director of Sri Jagannath Hospital and Research Center, Ranchi. She is a practicing anterior segment pediatric ophthalmologist and also practicing medical retina. She is our past Chairman Scientific Committee of Jharkhand Ophthalmological Society. Dr. S.K. Mitra, a prolific surgeon. He is an anterior segment surgeon with special interest in phacosurgery. He is the Chief Ophthalmologist of Tata Tinplate Company of India Limited in Tinplate Hospital and consultant phacosurgeon of Drishtidan Phaco Center in Jamshedpur. Dr. Malay Dwivedi, a very young dynamic surgeon. He did his MS ophthalmology. Excuse me, I request everybody to kindly mute themselves. Yeah, Dr. Malay Dwivedi, he's a pediatric ophthalmologist. He did his fellowship from Arvind Eye Hospital, Madurai. He's a consultant pediatric ophthalmologist, MGI Foundation, Jamshedpur. Dr. Rekha Singh, She has done her MS from BHU Varanasi. She is a senior consultant, Department of Ophthalmology, Tata Central Hospital in Dhanbad. Dr. Seema Patwari, she is a DO from AMC, Medical Retina Fellowship from MNEH Chennai. She is the director of Jharkhand Diabetes and Eye Center in Dhanbad. Dr. Deepak Lakda, he is MS from RIO RIMS and as an associate professor, cataract and glaucoma services in RIO RIMS, Ranchi. Dr. Sunil Kumar, he did his MS from PGI Chandigarh. He is an ex-senior resident from PGI Chandigarh. And he's also an associate professor in charge, Cornea Clinic and Eye Bank, RIO RIMS, Ranchi, doing excellent work in RIMS. Dr. A.N. Singh, he is an anterior segment surgeon practicing young ophthalmologist from Hazaribagh. Dr. Vikram Bhalla, he is also an anterior segment surgeon practicing in Ranchi. Dr. Vivek Kedia is an MS from Manipal University. He is a fellow of phaco-refractive surgeries from Netradhama, Bangalore. He is a director of Kedia Eye and Maternity Center, Jamshedpur. He is a phaco-refractive surgeon from Jamshedpur. He is also the joint secretary of Jharkhand Ophthalmological Society. Dr. Rahul Prasad, he did his MS from RIO RIMS, and he is also an associate professor in the Cataract and Retina Services, RIO RIMS. Dr. Anand Shushrut, he is a director of Anand Eye and Mother Care. He is a senior cataract and medical retina specialist. Dr. Prasoon Kumar, he is a fellow from Shankar Nethralaya, Chennai. He is a high volume cataract phaco surgeon practicing since last 15 years. Dr. Hemlata Bharati, she did her MS from RIMS. She is an ex-senior resident from RIMS and fellowship in pediatric ophthalmology from Madurai. Dr. Vijaya Jojo, she is a consultant ophthalmologist in TMH Jamshedpur. She has specialty interest in medical retina and retinopathy of prematurity. Dr. Poonam Singh, she is a DNB and glaucoma specialist, senior consultant in Tata Main Hospital, Jamshedpur. Dr. Bharati Sharma, she is a senior consultant in the Department of Ophthalmology, specializing in cornea, Tata Main Hospital, Jamshedpur. She is also a cornea fellow from Shankar Nethralaya and an ex-consultant at Shankar Nethralaya. Dr. Tirthajit Moitra is a consultant at Jagbandhu Eye Clinic, Hazaribagh, practicing anterior segment and medical retina. He did his long-term fellowship from LVPI and medical retina from Bangalore. Dr. Nitin Ganesh Dhira, he did his DOMS from Ranchi and DNB from LVP Hyderabad. He is a consultant ophthalmologist with special interest in cornea and a consultant in Jamshedpur Eye Hospital. Dr. Alok Kumar is an anterior segment surgeon and medical retina expert, consultant at Lok Nayak Jayaprakash Hospital, Kodarma. Jayanti Kashyap, she did his MS from RML New Delhi, DNB, ICO Part 2, and she is working at Divisional Railway Hospital, Dhanbad. Dr. Archana Kumari, she is a very young vitreoretina surgeon at Prasad Eye Hospital, Ramgarh, Bhagwan Mahavir Medica Super Speciality Hospital, Ranchi also. Dr. Indranath Prasad is an anterior segment surgeon at Prasad Eye Hospital, Ramgarh. Dr. Neha Shilpi, she did her MD from RPC AIMS, fellowship in phacoemulsification and refractive surgery from Narayan Nethralaya, Bangalore. She is a senior resident at RIO RIMS. Dr. Reena Surwar, she is a proficient cornea surgeon. She works as a senior resident at RIMS. Dr. Tanisha Ojha, she did her MS from TMCH Patna and senior residency from AIMS Patna. She did her glaucoma fellowship at VIRC New Delhi and FICO also in glaucoma. Dr. Sarojini Murmu, she did her MSI from RIMS Ranchi. She is a senior resident at RIMS Ranchi. And she has done her fellowship in anterior segment and IOL from Arvind Eye Hospital, Madurai. So it's really encouraging to see so many doctors from Jharkhand and the surrounding areas taking interest in this webinar. So now
let's not take everything lightly just because we are doctors.
Yeah,
So now we have with us Dr. Ravindra Kashyap. He is based in USA and has done a lot of research in COVID-related drugs and lots of research on all these. So I request Dr. Vibhuti Bhushan to introduce our international speaker, Dr. Ravi Kashyap. Dr. Ravi Kashyap, are you there?
Yes, I'm here.
But I can't see you.
Is my screen visible?
Yes, it is.
Yeah, welcome you, sir, Dr. Ravindra Kashyap. It's really heartening to see you taking your time off for this webinar and enlightening us in your specialty. Just a brief introduction. Dr. Ravi Kashyap is the medical director of the Unity Point Methodist Sleep Center and associate medical director of the Unity Point Methodist Medical Intensive Care Unit. He is also conducting multiple clinical trials associated with COVID-19 infection. He is the principal investigator for the ongoing trials involving treating patients with convalescent plasma, acalabrutinib, prevention of thromboembolic events using Plavix plus minus Lovenox, and use of agent EBO5, which is a monoclonal antibody. He will be a site lead for National Institute of Health conducted study for post-acute sequelae of SARS-CoV-2 PASC, also known as long hauler syndrome, which is pending approval from NIH. We welcome you, sir, once again, and I hand over the dais to you to begin with your presentation.
Thank you.
Over to Dr. Ravi Kashyap.
Thank you so much for that kind introduction. I hope you can see my screen.
Yes, sir, very much.
Yes.
So thank you so much for the kind introduction. And as we are all in this pandemic, I thought we can share some information amongst each other so we can fight this pandemic together. So with that, I think I'll move on with the next slide screen here, if I can. Okay, so briefly, I don't want to spend time on this. I know all of you are aware of it, but just to kind of show this diagram of the COVID-19, in the center, as we can see, there's the RNA surrounded by these proteins, and we keep hearing about this spike glycoprotein. I'm sorry? Can you you're not seeing this? Okay.
I can see. It's visible. Slideshow mein jaiye.
Okay. Is that better?
Yes. Now it's
Okay.
in full screen.
All right. So now, so as we can see here, that the SARS-CoV-2 attaches to cells using spike protein, and this protein binds to ACE2 receptor, a molecule that sits on the surface of human cells. After binding to ACE2, the virus undergoes structural change that allows it to fuse with the cell. Once inside, the virus is able to reproduce. And I'm sure you know all about this. Just want to touch base upon that. I would not go through this slide about the common signs and symptoms of COVID-19. Pretty much it mimics any other viral disease. I want to spend some time on this slide. So we know about the tests, RT-PCR and rapid antigen tests. So I'm going to just differentiate those two. So nucleic acid amplification test is what we know as RT-PCR, and rapid antigen test is is antigen test. The intended use for both of them is to detect current infection. Obviously, the nucleic acid amplification test or the RT-PCR detects the RNA, whereas the antigen test detects antigens. The specimen will be from nose, nasopharynx, sputum, or saliva. So what is the major difference between those two comes to this slide, this part of sensitivity. So the RT-PCR test is highly sensitive, whereas the antigen test is moderately sensitive. What does it mean? It means that there are very few false negative with the RT-PCR, where the false negative could be higher in the antigen test. And that's why many of the authorities, including when you're traveling abroad, they would not accept the antigen test because it may miss some infection. They want you to have RT-PCR test. Specificity is high in both. That means there are very few false positives. That means if you are positive with the RT-PCR or with the antigen test, you have a high chance of having this infection. So what's the benefit for antigen test? It is fast, it's cheaper, it can be done on the spot. So many universities in this US, they are doing the antigen test on the students twice a week. So it's cheaper for them to do it and they get the results fast. So there are values to have antigen test as well. Now, I keep hearing about the cycle threshold or CT value for RT-PCR. It is not commonly reported in the US. And the reason is, what is the cycle threshold is basically how many cycles it takes to detect the virus. Higher the cycles, lower the viral load. So if the cutoff is 35, if they don't see the viral load by the 35th cycle, they stop the test. That means the lower the cycle threshold, higher the viral load. So why it is not reported? Because the CT values from viral RNA vary depending on method of specimen collection, specimen source, transport, and the time from infection to collection to analysis. No standard exists to validate quantitative assays that produce a comparable results from labs and manufacturers. Therefore, including the CT value and all positive results may be confusing and sometimes misleading to ordering providers as well as patients. So in general, the consensus is that the lab should not routinely report the CT values, but if a physician asks for it, they should be provided. Why I say that, if somebody's CT value is low and the viral load is high, does not necessarily mean that they would have a more severe infection. Or if the CT value is higher, the viral load is low, does not mean that they would not develop severe infection. It just depends when it was collected, what disease process you were in when it was collected. Now, serology test, also known as antibody test, again, it's not commonly used in the US, but I do see a value of this. So I just want to speak, what does it mean? So negative test on SARS-CoV-2 antibody test means antibodies to the virus were not detected in sample. What does it infer? It means the person has not been infected with COVID-19 previously, or it means patient had COVID-19 in the past, but did not develop or has not yet developed detectable antibodies. It is unknown if all infected individuals will develop an undetectable antibody response. Or it may mean the result may be wrong. It may be false negative. This occurs when test does not detect antibodies, even though the patient may have specific antibodies for SARS-CoV-2. What does a positive result mean? A positive test means that patient is a possibility the patient was recently or previously had COVID-19. There's also a chance it's false positive, as it can detect the other coronaviruses other than SARS-CoV-2, which can cause common cold. And the more important thing is that a positive antibody test does not necessarily mean that the person is immune for SARS-CoV-2 infection, as it is not known whether having antibodies to SARS-CoV-2 will protect them from getting infected again. It also does not indicate whether the person can infect other people with SARS-CoV-2. So I'm not opposed to it, but it has to be interpreted very in details before we make any inference on what it means. Changing gears about the vaccine, I won't spend much time on it, just to kind of consolidate what is available in the world right now. So the Pfizer and Moderna, they have mRNA vaccine. The Pfizer is given 3 weeks apart. Moderna is given 4 weeks apart, two jabs. The Pfizer has pretty stringent requirement for storage, -80 to -60 degrees centigrade. Moderna is -25 to -15 degrees centigrade. Then there's a viral vector, where is a benign virus has the spike protein from the COVID-19, and that's how it makes antibody. And the ones available are the Oxford AstraZeneca or Covishield in India, Sputnik, and Johnson & Johnson. Johnson & Johnson is only one shot. Then the inactivated virus, which is the CoronaVac, the Sinopharm, and the Covaxin available in India. And there's a protein-based, which is a Novavax. Basically, it's nothing to do with the virus. They have taken the protein in the lab and have simulated the spike protein, and that's used as the antibody formation against the coronavirus. I will not spend much time on this slide. You all know it. Basically, the most common way to spread the infection is by respiratory droplets, and it can be it will range up to 6 feet or 2 meters. That's why the recommendation is to stay beyond, to maintain the social distance for 2 meters or 6 feet. Now, it can sometimes be airborne as well, especially indoors. So there is some evidence that if there's in indoors with the poorly ventilated areas, it can linger in the air for longer, and it may cause infection even for the people who are more than 6 feet apart, or even after the person infected has left the room. That's why it's strongly discouraged to be gathering indoors. Again, there are some questions about the contact with the contaminated surface. Not very common, but we need to be careful. If there is a respiratory droplet has gone to a surface and we touch it, and we touch our eyes, nose, or mouth, then we may get infected. Not a common way of transmission. There are some incidences where the COVID-19 has thought to be spread from people to animals, but the reverse, meaning by animal to people risks, animal to people transmission risk is very little. Again, I won't spend time on this. Basically, wearing the mask, maintaining a social distance, getting a COVID vaccine, washing your hands, staying home and isolate if you're infected, and routinely clean and disinfect frequently touch surfaces, and take other steps to spread at home. Changing gear again, briefly discussing the treatment options, and I would be very clear here that this is all evidence-based. Does not mean that if somebody is treating a patient based upon the clinical judgment is wrong. So what I'm going to present is what is recommended in the US based upon the FDA or CDC. So this is not available in India, but if a patient is positive for COVID-19, they're not sick yet, they're just positive. And if they are at high risk of developing severe infection, so age 65 and above, or a younger patient, but they have a higher chance of developing more severe COVID-19 infection, the combination monoclonal antibody are given. So one of them is bamlanivimab and estisipimab. So this is a combination of antibody, or casirivimab and imdevimab. So there's a monoclonal antibody given as soon as they get the infection, within 10 days or sooner than that. Basically, it fights against the virus and does not let them grow. Has been beneficial. I have seen my patients, and they have said immediately after getting that they got better. Evidence shows that the hospitalization in this population has decreased from 12% to 5%. It is not recommended to be given an inpatient setting. Convalescent plasma was one of the first ones we used. I was part of the study as well. But based upon the evidence as of today, the COVID-19 treatment guidelines recommend against the use of COVID-19 convalescent plasma for the patients hospitalized, unless they are in the clinical trial. And now the high titer convalescent plasma is authorized under EUA, or emergency use authorization, for the treatment of hospitalized patient with COVID-19 and impaired immunity. So we are not using that commonly anymore. Remdesivir is the intravenous nucleotide prodrug of adenosine analog. It binds with the viral RNA-dependent RNA polymerase and inhibits viral replication through premature termination of RNA transcription. It has demonstrated in vitro activity against SARS-CoV-2. So currently it's FDA approved to be used in the hospitalized patients, both for adult and pediatric population, though it is not strongly recommended for people who are very sick, as we'll see in the next slide. So current recommendation is for use in hospitalized patients who are requiring supplemental oxygen. However, it is not routinely recommended for patients who require mechanical ventilation due to the lack of data showing benefit at this advanced stage of the disease. It should be carefully used with the kidney disease, especially with GFR less than 30. Now, so far, the clinical study have not proven mortality benefit. They have shown to decrease the duration of hospitalization by using this medication, and further studies are undergoing. Ivermectin, reports from the in vitro study shows that ivermectin acts by inhibiting the host importing alpha/beta-1 nuclear transport proteins, which are part of the key intracellular transport process that viruses hijack to enhance infection by suppressing the host's antiviral response. In addition, ivermectin docking may interfere with the attachment of the SARS-CoV-2 spike protein to the hemocell membranes. So basically, inhibiting the attachment as well as the replication. But studies have not proven beneficial for the COVID-19 infection and currently not recommended by NIH or FDA, but the studies are ongoing. Fabiflu or favipiravir, it is the antiviral commonly available in India. It is shown to stop the SARS-CoV-2 replication process. Studies have shown to decrease the duration of recovery from infection, and many studies are ongoing across the world. Virafin, which was very recently got the EUA emergency use authorization in India, is an interferon alpha 2b inhibitor. In the past, it has been used for hepatitis C, given as a sub-Q injection 1 dose. Very limited data available in peer-reviewed journals. I tried to look for it. I could not find much information. The phase 2 trial had shown for the mild patients who are not on oxygen, once it was used, the viral load was undetectable in 7 to 14 days more commonly than the people who did not receive that. Phase 3 trials are on the criteria. And the last one is the sickest patient hospitalized and requiring invasive mechanical ventilation or ECMO. Recommendation is dexamethasone plus minus tocilizumab. So that's the recommendation for the society in US. So I'm sure that we are hearing myths and facts, myths from the patients and a lot of questions. I have compiled some of them here. If you look at the language, it is more designed for the population that you'll be talking to. I'll request, if you have some myths, please share that with me. So myth, the COVID-19 vaccines are unsafe because drug companies created them quickly. And the way we respond to that to our patient, that because we are in a global pandemic, drug companies spend lots of time and money quickly making the COVID-19 vaccine, but that does not mean they're unsafe. All vaccines in the US go through strict studies, and so far, and similar in India for that matter, to make sure they are safe and will work. The FDA in India, the drug society over there, which regulates vaccine, also approve them before it's being used. Another myth that vaccines will make me sick with COVID-19. And the way we respond to that, none of the approved COVID-19 vaccine in the US or that other companies are currently developing have the live virus that causes COVID-19. The bottom line, a COVID-19 vaccine cannot make you sick with the disease. Myth, I won't be able to get or stay pregnant if I take COVID-19 vaccine. Fact, the myth has been going around on social media. It claims that antibodies made from the COVID-19 vaccines will bind to proteins in the placenta and stop pregnancy. Scientific studies do not support this idea, and no evidence links COVID-19 to infertility. Myth, vitamin D and mineral supplements can cure COVID-19. Fact, vitamin D and C and the mineral zinc can indeed boost your immune system and protect against viruses. This is mainly true for people who lack these supplements, but there is no evidence that they are a cure or treatment for COVID-19 if you already have the disease. Myth, drinking warm water rinses the COVID-19 virus from my throat. Fact, while water is vital for your overall health, science does not back up the idea that drinking water, warm water, protects you from COVID-19. The only thing it might do is to soothe your throat and ease the cough if you're already sick. Myth: taking a hot bath can stop COVID-19. Fact: the idea behind this myth is that high temps can kill the coronavirus, but taking a bath in water that's too hot can burn your skin. The best way to ward off COVID-19 is to wash your hands with soap and warm water. Washing gets rid of viruses on your hands so you could transfer to your eyes, nose, and mouth. Myth: rinsing my nose with saline will stop COVID-19. Fact: there is no proof that rinsing your nose with saline protects you from getting COVID-19. This myth may stem from the evidence to use saline in your nose or to treat a common cold, but it does not actually stop infections. Myth: I have a COVID-19 infection, so I'm immune. Fact: scientists have studied similar viruses and say it's possible to get COVID-19 more than once. They are still learning more about how likely you are to get infected again, how often it happens, and who has a higher chance of getting the disease again. Even if you have had COVID-19, you still should wear a mask in public, stay away from the crowds, and wash your hands. Myth: I have allergies, so I cannot get the COVID-19 vaccine. Fact: in rare cases, some people have developed anaphylaxis to the COVID-19 vaccine. If you are allergic to any ingredients in the COVID-19 vaccine, you don't get the shots. But if you have an animal, food, pollen, or other types of allergies, you can get vaccinated. Myth: a negative COVID-19 test means I'm not infected. Fact: if you test negative, it only means you likely didn't have COVID-19 when your sample was collected. It is still possible to test positive later and get sick. Researchers have also found that some tests show a false negative result. So even if you test negative, you should still protect yourself from the virus. Myth: small gatherings don't spread COVID-19. Fact: nursing homes, prisons, and other large groups in close contact are driving the spread. But small get-togethers are still a source. You raise your odds of getting COVID-19 when you gather with people who are, number one, outside of your household, means okay to stay with your household people, not social distancing or wearing masks. And keep in mind that some people with the virus don't show symptoms but can still spread it to others. Myth: children who develop COVID-19 don't get critically ill. Fact: most children with COVID-19 have mild symptoms or no symptoms at all. However, some children get severely ill from COVID-19. They may require hospitalization, intensive care, or mechanical ventilation. In rare cases, they may also die. Although the CDC reports fewer children have been sick with COVID-19 compared with adults, children can be infected and become ill with the virus that caused COVID-19 and also spread the virus to others. Children, like adults who have COVID-19 but have no symptoms, can spread the virus to others. Myth: there are no long-term effects of COVID-19. And this is a hot topic right now. We call them long haulers. In fact, there's a study being conducted by NIH, and I'll be the site lead for that study. It'll be a long study. So the way we explain to the patient is that while most patients with COVID-19 infection recover within a few weeks, some people, which is up to 10%, who had mild version of the disease continue to experience symptoms after initial recovery. These people are often referred to as long haulers. Older people and those with many serious medical conditions are the most likely to experience lingering COVID-19 infection, but even young, otherwise healthy people can feel unwell for weeks to months after infection. The most common signs and symptoms that can linger include fatigue, shortness of breath, cough, joint and chest pain. And I'm seeing more patients are also complaining of fogging of the brain, that they forget from time to time. In addition, organ damage can occur to the brain, heart, and lungs. Much is still unknown about how COVID-19 will affect the people over time. Myth: COVID-19 is an invented pandemic to cover up the effects of 5G radiation. Fact: 5G is the fifth generation mobile network being rolled out across the US and the world. The belief that COVID-19 and 5G are connected comes from a long-standing myth that wireless signals can sicken people specifically with electromagnetic sensitivity, or they may weaken your immune system. There is no evidence to support these claims. To be clear, COVID-19 is a real disease that has affected lives of millions worldwide. There is no connection between rollout of 5G technology and the COVID-19 pandemic. Myth: wearing a mask will increase the amount of carbon dioxide I breathe and will make me sick. Fact: for many years, the healthcare providers have worn masks an extended period of time and with no adverse health reaction. The CDC recommends wearing cloth masks while in public, and this option is very breathable. There is no risk of hypoxia or hypoxia, which is lower oxygen levels in healthy adults. Carbon dioxide will freely diffuse through your mask as you breathe. If you feel uncomfortable in your mask, try to limit talking and breathe through your nose. This will reduce the humidity level in your mask. Myth: COVID-19 vaccine affects menstruation and makes them irregular and heavy menstruation. Fact: no scientific evidence suggests that COVID-19 vaccines are making periods irregular. Many female patients with COVID-19 infection have reported heavy menstruation. Some females have also mentioned that they have experienced irregular period after COVID-19 vaccine. Myth: COVID-19 vaccine should not be taken by breastfeeding mothers. Fact: because non-replicating vaccines pose no risk for lactating mother or the infants, COVID-19 vaccines are also thought not to be a risk for breastfeeding infant. Therefore, lactating mothers may choose to be vaccinated. And then take-home message, as you know: use masks, wash your hands, maintain social distancing, avoid indoor gathering, and please take the vaccine. So with that, I will take any questions which if you have.
Unmute yourself, Dr. Bharti.
Yes, I have two questions. Number one, how to reconfirm hypoxia? Means we know that we have to take it here, but sometimes in the right middle finger we take, sometimes the reading comes low, sometimes after some time it comes high, and sometimes it is showing 93. So how to reconfirm it? Means is the 6 minutes walk test is essential? First question. The second question is how to prevent the silent hypoxia, because many patients, they complain, many people around us who have come back after recovering, they complain that suddenly their condition starts worsening, and after coming back from hospital and the oxygen level starts going down. So how to recognize and how to prevent this silent hypoxia?
So good question. So let me just answer both questions in one. Explain both things. So what we recommend, anybody who is positive for COVID-19 or they are highly suspected to have COVID-19 infection, to use the pulse ox. So one of the most important things is to have a good pulse oximeter, good reliable pulse oximeter. Now, whichever finger they are checking the pulse ox should not have any nail polish, because the way the pulse ox works is by looking at the color of the nail bed. So there should not be any nail polish at all. So that should be clearly visible. Now, when you check the, so that's one thing. So checking the pulse ox is very important, and we'll discuss in a second. Now, checking the pulse ox, if you just put the pulse ox on your finger, it may fluctuate. But wait for a second. Do not be panicking if you say 85%. Keep it on. And the pulse ox also shows the heart rate, pulse rate. So the way we say that, make sure the heart rate matches with your pulse. So make sure, then it's actual reading. Because if your pulse rate is 60 and your heart rate is 80, that means it's not real. And also look at the waveform. But the most important thing is, for the patient, maybe a little more difficult. So I said, well, if you say 85%, don't panic. Just take some nice slow breathe and keep for a little bit and make sure it has stopped fluctuating, that it is stabilized. Keep your finger steady, put on a table or something, keep it steady and let it stabilize. And when it becomes steady, you know the numbers, right? So that's number one. Number two, if your oxygen level is, say, suppose about COVID-19 infection, you have flu-like symptoms and they have confirmed, and they saturate 98%. What I recommend, and I'm not saying that's the everybody should recommend that, but I recommend stay home. If you have fever, take the analgesics or Motrin, or sorry, ibuprofen or paracetamol if you need to, but stay home, maintain a social distancing, and make sure that you stay away from other people in the family, or wear a mask, wash your hands, etc. Vitamin C, zinc, vitamin D, there's no harm taking those. I don't think there's a problem. They should take that. 6-minute walk evaluation, if there's any concern that, if it's basically what it is, that we need more oxygen when we walk. So if you're really concerned and say, well, I don't know, my SAT's 98%, but would it drop? Well, good point. So, you 6-minute walk, whatever time you can walk at the normal speed that you normally walk, go back and forth without stopping, keep the pulse ox on your finger. Now, don't believe the pulse ox when you're walking, because sometimes as you are, you may be fluctuating. Once you get tired a little bit, then, or you walk for 6 minutes, then sit down, steady your finger, and check your pulse ox and see what the numbers are. So yeah, it's a good idea. When to panic, or not panic, when to be alarmed if your oxygen level drops by 3 to 4%. So for example, today is 98%, and tomorrow is 98%, and third day is 94%, and it's steady, that's the time to be concerned. That's when you need to see, everybody should see the doctor to see what to do. Do a CT scan. And beyond that, I would not go to the treatment process because it's very individual. But that's the time I would recommend to have some treatment that could be more invasive, being hospitalized, maybe, remdesivir or steroid, whatever that may be, is very individual. But that's when the people should be concerned getting more invasive testing done. 95% people would probably need none of that. At least 90%, I don't know with the new variants. So a vast majority of patients will do fine by just staying home, taking paracetamol, etc. Yes.
Bharti,
Yes.
I have got a question. Few questions.
Sir, Anand Thakur sir has a question. Please, sir.
Absolutely.
Yeah, my first question is, I don't know whether Papu remembers of me or not.
Of course I do.
Thank you. The first question is there any role of antihistamines together with paracetamol when there is early stage of fever and cough?
There's no proven medicine for antihistamine, but it's very benign medication. If you really want to take it, you can take it. I don't know antihistamine will have a high role. On the other hand, some people are suggesting, which is a little more safer. And again, it is not evidence-based, and I'm just talking just what I do or I recommend. So this is not, I'm not going to back up with any evidence. I would recommend inhaled corticosteroid. If you really want to be like, okay, I want to do something, I don't want to be more aggressive, inhaled corticosteroid will be probably safer to do at that point. I don't have any evidence to back that up. But if that's a concern, that I would recommend that personally.
Actually, what I feel, I'm not talking about the condition when the RT-PCR is positive. No RT-PCR test has been done. The person has simple mild fever, cough, a little cold. So in that situation, just I asked you whether we can go with the antihistamines together with paracetamol.
Yeah.
Then,
yeah. I mean, it hurts with allergies. So yes, definitely, no question about it. Just for symptom relief, I don't see any problem with that.
Right. Number two, in the first phase last year of COVID-19 in India, the recommendation of drugs were different. People used to give a lot of SCQS and azithromycin. Now, this in second wave, I see that for prescriptions that they advise for the, say, suspected patient or for the convalescent patient, that is doxycycline. Is there any role of doxycycline in improving COVID-19 cases?
There is no, again, this is by no one of the proven antibiotics, any antibiotics have been proven to be helpful. So whatever works to prevent the secondary infection, as long as they're safe, there's nothing wrong doing that. But there's no evidence to show antibiotics work.
Okay. The most important question that I want to know from you, what should be the oxygen level when a person should feel that I need really some very good hospitalization, because I have seen in my cases, for routine cases that I do cataract surgery, I always get examined pulse oximeter each and every patient. And I remember few patients who have got oxygen level of only 85. Repeated checkups, lot of breathing, lot of deep breathing I got done, but it didn't improve. Then I sent to the physician. He also checked thoroughly, spirometry, this and that, all tests. And then his report was, his 85% is okay for him. Go ahead with the surgery, there will be no problem. And there was no problem. And in my personal family, nowadays we are doing regularly pulse oximeter testing of entire family members. What I didn't know was that nail polish. That nail polish that you have told me today, now I will take care of it. Number two, sometimes the oxygen level comes to say 88, 89, 85 to me also, to my family members. And when we breathe a little, 3-4 times in 5-6 times, deep breathing, it just goes high as 95-97%. So normally, in normal circumstances, if all this is there, even after a few breathing exercise, if the oxygen level remains at around a 90, 92, is there any need of oxygen supplementation immediately?
So good question. So number one is that the patient you described that has 85%, I may have to disagree that they would not need oxygen, COVID or no COVID. So anything below 88% consistently, especially at rest, is 85%. On walking, they may drop 80%, and they will cause pulmonary hypertension and cause like heart failure. So clearly, the patient who need oxygen, based upon the patient you described, not COVID, just in general, they will live longer if they use oxygen. So this is well proven. So I would do more testing to see a COPD is the most likely cause. Interstitial lung disease, they may have a shunting in the heart. I mean, there are multiple things. Not going through that, but yeah, they need to be on oxygen till it's recovered. Now, for COVID-19, knowing the baseline is important. So in general, if this less than 94%, it's not necessarily giving them oxygen. Is to be more concerned that do they need more invasive treatment now, would be dexamethasone or remdesivir or whatever that may be. So giving oxygen is one thing, but more important is to be careful about these patients that they are deteriorating, meaning they're getting a CT scan, etc. So more than giving oxygen is to be giving them more treatment. Now, there will be some patients, like you had described, some people may have 90. So 94% is the number normally they are recommending to be very careful about. There could be a patient with COPD. The baseline oxygen may be 94% to begin with, right? Then that's very difficult one to determine. Then you say that typically what we do is they drop by more than 3% from the baseline. So if they're 94% all the time before COVID, then we want to make sure that they're dropping by 2 or 3%, or get the CT scan of these patients sooner to make sure that we're not missing anything. Plus, they're at high risk anyways because they have COPD.
Thank you. Thank you very much.
You're welcome.
There is one question, simple questions, that patients who are COVID positive frequently ask you when, at what frequency you should check the oxygen level.
I would say 2 or 3 times a day.
But they said there is a study which says every 4 hours you should see the oxygen level saturations. I don't know what is the authenticity of the study.
I don't think any recommendation, but I mean, it does deteriorate. I think one thing about the COVID we have seen, especially in ICU and all, they don't deteriorate like on hourly basis. So they're very slow deterioration and they keep going down the hill. So if every 4 hours works, that's fine. I don't know, I will wake them up in the middle of the night, but at least checking 2 or 3 times a day to, in the morning, in the afternoon, in the evening, make it 4 times. I think there's no regular recommendation, but it won't hurt.
And sir,
Good evening,
Dr.
sir. Good evening. I have a question. Can I have a question, please? Good evening, sir. I'm
Yes.
Dr. Anupam Singh. I have a question, which is a
Yes.
case myself. This is my case. I was diagnosed as COVID-19 positive on the 13th of this month by the nucleic acid amplification test, because here RT-PCR is, by the time you get the report, another strain comes up. So I was tested positive, and after 14 days of the treatment, I was even on favipiravir and other drugs like doxy, ivermectin, and other things. And after 14 days, when I got tested, I was tested negative by the same test, what we call it TrueNat. So and again after like say 4 days, I again got retested because initially I was asymptomatic. Absolutely, my husband was tested positive first, and I contracted from him. So I got tested, and I got tested positive. But I never had any symptoms during those 14 days. After which, when I got tested yesterday, again, I was tested to be positive. And for the last 2-3 days, I'm having eye symptoms. I'm having itchiness of eyes, pokiness in the eyes, a mild chest discomfort, diarrhea, sore throat. So I actually want to know, what we have known so far is that the virus replicates during the first 9 days of the infection. So I have a serious question, that what about the infectivity? Am I still infectious? Do I still need medication? Or how should I go about it?
So, because there's a possibility you got reinfected. So what I would recommend is from the second exposure, you should again quarantine for 10 days. So
what about
meaning by you,
medication, sir?
Unless until you have symptoms, I mean, obviously, if you have chest discomfort and hypoxia, I will get the CT scan done. But I don't know that.
I haven't had a CT scan done, and I'm not having hypoxia either. My saturation is doing fine. It's in 98, 99 all the time.
Okay, and that's what I was saying, that this is very individual, physician driven treatment. If suppose, and I give my opinion, if you're my patient, and the way I would not have treated you from the beginning itself. That's my opinion. This is my treatment plan. I would have said, take the paracetamol or whatever you need to take, check the pulse ox. Now, obviously, with the diarrhea, you need to treat that, loperamide or whatever medication you want to take for that. But I would not have treated you with any other treatment beyond the supportive treatment. So I would still recommend for you, if you go with evidence-based, that just do the supportive treatment, but take the precaution for next 10 days from the second time you got exposed.
Okay, sir, but I never got the exposure. And what about the medication? Should I go ahead with anything, or and what about HRCT? Should I get it done, or I don't need it?
If your pulse ox remains 98, 98, 99%, I don't see a value of the CAT scan. If you're really concerned, you can take the pulse ox after walking and see if that shows anything.
Okay. Thank you so much, sir.
But otherwise, supportive care is what is recommended, and it's the safest way to go.
And no other medications, no antivirals, no indications of that?
And as I said, we don't, and we have. There's no. I mean, antivirals have shown to decrease the viral load. But that's too late for that now.
Yes,
but I don't know that it'll be safe to give any medication at this point.
But I'm still infectious. Is that what you're trying to say?
If it's positive, you got exposed to your husband, you said? That's what I heard?
Yes, but he was infected before me, and now his infectivity level is low. He is still positive with a low infectivity. So I am seriously confused whether we are still infectious, or how should we go about it?
No, so no, that's a good question. And you or anybody could be positive up to 3 months. We have seen patient ICU after 45 days. So typically the recommendation now is that you have to quarantine for 10 days from the day you were positive, or the day you were exposed, or the day you develop the symptoms, and 24 hours symptom free.
Okay, sir. No, I was also confused about whether the reinfection is happening, or is this a post-COVID sequelae?
It's most likely post-COVID sequelae, and we don't know. There is we're still trying to learn whether the reinfection happens or not. Less likely, but possible.
Okay. Thank you so much, sir.
You're welcome.
Sir, I have a question.
Sure.
Sir, yeah, I want to know that if a patient comes to us with the COVID negative report after he has been COVID positive, after how long is it safe for us to operate for a cataract surgery? So
Once
after
they
how
are
many days should we operate the patient?
10 days after they have been positive, you should be safe to do the surgery. If you're in close contact though, if you're in close contact like your surgery you're doing, it may
Yes,
not be
sir.
a bad idea. Yeah, it may not be a bad idea to get that COVID negative testing done and tell them to quarantine. So typically what we tell them that get the testing done and stay home. Don't get exposed. And the testing comes back positive, you can do the surgery. Meaning what I'm trying to say is that even if they were negative and they have been exposed after that and you do surgery, you may be exposed.
Excuse me, sir. One question.
Sure.
Yes.
Yeah, what is the role of low molecular weight heparin?
Good question. So what we are seeing in the patients with the more severe infection, especially in ICU, there's high incidence of the DVT and PE. We are seeing that. Now, I don't know how to, we don't know how to prevent that. So even they are on the low molecular weight heparin, they may develop the DVT and PE.
What is the dose, sir? What is the dose that we can use?
Dose. So outpatient, we don't recommend anything. Now, I'll tell you what we do, and it's not fully scientific based. So what we do is the half dose. So for example, as you know, like, we do the Lovenox, low molecular heparin, 1 milligram sub-Q BID. We do 0.5, half milligram per kilogram body weight BID. But that's our practice. That's what we're doing.
So actually, we have started our COVID facility just now. And we are treating patients with oxygen saturation below 90.
Yes.
So that's for them, we are thinking to start them on low dose heparin. So
yes,
what doses can be started for them?
So the Lovenox would be 0.5 milligram instead of 1 milligram. 0.5 milligrams per kilogram ideal body weight sub-Q BID will be middle of the road. And if you see that, and now I'll suggest check the D-dimer of these people, because D-dimer will be more beneficial for these sicker patients. If you start seeing the D-dimer going like based upon your level, like our levels is 0.5 being normal. So if you go to 2 to 3, then we get concerned. And there's no contraindication with fully anticoagulate them. On the other hand, if the D-dimer is less, like 0.5 or 1, high but not too high, we go with half the dose. And again, this is very much our individual approach, no scientific based, not scientifically based.
Okay, thank you, sir.
You're welcome.
Sir, I had one question.
Sure.
Yeah, sir, this is regarding one of my senior doctor's husband. Like recently, our hospital has also been made COVID center. So, sir, this is his 11th day of infection, and he's on BiPAP. Like his oxygen saturation has been falling like below 60 for past 2 days. So he's on BiPAP and he's maintaining like around 74, 75. So here
it's a
they
PO2
have
or saturation?
SPO2, sir. SPO2.
SPO2. Okay.
Okay. Yes, sir. And we have started like earlier. He was on intravenous dexamethasone and then enoxaparin and other IV antibiotics. But then someone suggested to start him on pulse methylprednisolone IV. So from last night, because his saturation was falling, yesterday it was below 60. SPO2 was below 60. So we have started in on IV methylprednisolone 500 for 3 days. So sir, any other like quick, because here his D-dimer has not been done, but then the neutrophil lymphocyte ratio that is quite raised. But he's on BiPAP. Yes,
not on oxygen?
With the that low saturation, I would say recommend to be patient to be on the ventilator. I mean, the saturation is only 75%.
Yes, sir. He's on a non-invasive that BiPAP, but not on invasive one, but on non-invasive ventilator.
But then, is he on oxygen?
Because that.
Yeah. Yes, ma'am. Yes, ma'am. Along with that, oxygen is also high flow oxygen.
That's not enough. Like 75% is, is not.
Yes, sir. Yes, sir.
Very good. But beyond that, no, that's one thing I'll recommend to be intubated. But beyond that, I would say, if the D-dimers are depending on D-dimer, if is available, one dose
Okay. Hello. Yes. Hello.
Yes, you're
बोलिए.
audible.
And I
Hello,
don't
sir.
think
I
that
have one
another
question.
steroid will be
Please
beneficial.
emphasize again, sir, on vaccination on breastfeeding mother,
Thank you, sir.
pregnant women, and post-COVID patient.
So breastfeeding with the vaccination has shown that it does not interfere with the breastfeeding. It does not cause any problem to the child. So it is recommended to give vaccine to the breastfeeding mother.
Okay. And in post-COVID patient?
Post-COVID patients, as long as they're recovered, and I would say when there's a recover, meaning by at least 10 to 14 days after they were positive, they should, once they develop antibody, they should be able to breastfeed.
Excuse
And
me,
it
sir.
is
So what is the level of antibody titer so that we can think we are immune at least for
I
3
will-
months?
Yeah, as I was saying, we don't know. I don't think antibody titer has much value at this time. We don't know we definitely will develop the antibody. We don't know what level will be protective. So that's why it is not till it is validated. There's no validation done yet. So antibody test really at this time, other than the fact showing that you may have been exposed, has no other value. But there's no validation with any research that this is a good level. This is not such a good level. So I would not recommend to base any clinical judgment based upon antibody test.
This is a real confusion here. Many people think that their antibody titer is 190, 200. So they are very safe. And people who develop antibody very less, like 20, 15, they are more prone. But now with your talk, it is very clear that antibody titer thing and protection from COVID-19 at the moment has no validation. And I have one question: how you will differentiate an inflammatory pneumonia from a clot? Lot of talk going on, inflammatory pneumonia, then this is clot pneumonia.
Yeah, and I mean, I think that what they might mean is that the pneumonia with the DVT and PE. So that's what they might be meaning by that. So obviously, inflammatory pneumonia is what the COVID-19 pneumonia would be. That's the reaction to the COVID-19. Now, if they also have the DVT and PE, and that will be more like developing clot, and that's a very difficult thing because I tell you from my practice, I have been unfortunately lost a lot of patients. But you also see that if you give them too much of the anticoagulation, they may bleed. So they are also high risk of bleeding. They're also high risk of DVT. So we keep a very close eye onto it. And it's very difficult balance to maintain. That's why we went with half the dose of the anticoagulation if they're not positive. And the moment we suspect they have DVT PE, then we immediately send them for testing, confirm it, and do the full dose.
Sir, one question I have got. We are asking patient for RT-PCR before all the surgery. So validity of the test, because we are getting the report after 2-3 days, then within how much time we should operate that patient?
So that's what I was saying. Typically what we recommend that you get the RT-PCR test done and isolate. So if they takes 2 or 3 days, we should wait for 2 to 3 days. But for those 2 to 3 days, the patient should isolate themselves so that if the PCR test come back to be negative and they have not been exposed to somebody. So whatever time it takes, don't hurry. I think I will wait for them to get tested. Is saving you and your staff from getting infected because you'll be in close contact with those people, those patients.
So another question, when do you become eligible to donate plasma after having an infection?
So, the typical recommendation is anywhere about a month, 15 days to a month after being COVID negative, you should be eligible to give the plasma.
And how frequently can you donate plasma?
As long as it's safe, based upon the local the guidelines, as long as it's safe to give plasma, meaning by to draw the blood. And I think it could be every 3 weeks to a month just to save you from not getting too much blood taken out, but it should be every month or every 3 weeks.
Okay. Thank you, sir.
So apart from drug sessions, I just wanted to know your take on lockdown in this community transmission period. Is it effective?
It is effective. There's no question about it. We have seen that in our community itself, and we have seen the surge following a major event. And I'll tell you, like, for example, um, we have a Thanksgiving and people get to meet, and it's very important for the people. And we have seen a surge post Thanksgiving, 14 days after that. We've seen a surge 14 days after the Christmas. And right now we're going through a surge, a pretty severe one, with the spring break. Spring break, people go and meet, and so we see the surges. So it's clear that if the people stay lockdown, meaning by I won't say lockdown. What I'm trying to say is to separate and maintain the distance 6 feet.
So 2 weeks will be effective, or it will be like 3 weeks or something like that?
The how long to isolate?
We isolate for 2 weeks, I think.
Yeah, I mean, and again, follow the local guidelines. I would highly recommend that. What we have recommendation local guidelines, our guidelines is 10 days from the day of exposure and 24 to 48 hours without any symptoms. But 14 days is even better. I think I would argue against that.
So I have a question, like if the antibody titer plays a role in for plasma donor selection. I mean, if somebody has 1520, somebody has 190, so what is the cutoff mark for plasma?
There's no cutoff mark, but the higher so as I was in the beginning, the higher antibody titer that is supposed to be more effective, but even that did not pan out. So right now, the plasma is not recommended for any hospitalized patient except if they're immunocompromised. I would not say not use it, but the evidence does not show any benefit. But to answer your question, the higher the titer, the more effective it's supposed to be when you're given as to the patients.
So what titer is supposed to be good? Means 80, 100. What titer you say good?
Yeah, I mean, depending on the local level. So I think the higher, I mean, above 1680 would be high titer. So that'll be high titer value. Low titer will be like 15, 20, and then in between will be medium titer.
Plasma is only for hospitalized patients who are immunocompromised?
Yes. And as I said, we use that quite a bit in the beginning, every patient. And again, I was one of the site lead for the research done by Mayo Clinic. And the study came out and it showed that even with the high titer plasma, there was no benefit. As I said, and again, I will keep repeating myself, it's okay to treat the way you want to treat your patient. It is your prerogative and you should use that. All I'm saying, what evidence is showing that the plasma has not been found to be beneficial.
So I want to
know. I've also read somewhere that people who are symptomatic, their plasma seem to be more immunoprotective than the people who are basically asymptomatic. Is it true?
I have not seen anything like that. On the other hand, I'll be very concerned giving a blood from an infected person to anybody else, because if they in the viral phase, that means that they may be transmitting the infection. So I know I have not heard of symptomatic patients getting the giving the plasma. Plus, the antibodies should not, in general, just speaking from the common knowledge, that should not develop so quickly. And it is the antibody which is supposed to be protective, not the not anything else. I have not heard of that, and I don't know I would support that.
Okay,
thank you, sir. We know that plasma is given only from those people who are negative, and there are certain after 3 weeks they become negative, because by that time they have by that time they have
antibody.
Yes, we are starting.
One more question.
Sir, I wanted to know. For immunocompromised patients, those who are suffering from cancer, those who are elderly, whether Covaxin is better or Covishield. Is there any difference between taking Covishield vaccine or Covaxin?
So, I have a request. We have to sum up here because the other two speakers are getting late. So we can continue with Ravindra Kashyap after those two speakers if you are interested. So, so we can reconnect with Ravi Kashyap after those two talks. So let's first sum up this session. And I invite Dr. Beauty Banerjee, the Vice President of Women Doctors Wing, and my batchmate also, to conclude the session 1. And then again, we will come with the conversation part with Dr. Ravi Kashyap. So, okay, over to Dr. Beauty Banerjee.
Good evening, doctors. This was an excellent topic and discussion. The discussion was brilliant and very interactive indeed. Thank you so much, Dr. Ravi, for taking out the time for all of us and laying out so many things about COVID and all the myths we were treating unnecessarily. Actually, we were giving so many drugs which are actually not necessary, and you emphasized all of them. As this pandemic is new for all of us, we doctors too remain unclear about the facts and protocols on diagnosis and management of COVID patients. I'm sure this beautiful session by Dr. Kashyap will help all of us in managing our patients better than before and help them recover sooner. I want to thank all the doctors present here for their selfless dedication and patience which they have shown in these trying times. Yes, these are trying times, the worst we have seen, and I really hope the worst we'll ever have to see. The pandemic tested so much more than just our knowledge and clinical skills. And I'm so glad to see that all the doctors, however miserably they have failed, have not given up. And they are trying incessantly. Last but not the least, I want to thank my friend and colleague, the dynamic Dr. Bharti Kashyap, for organizing this event. I'm always inspired by her hard work and a vision for the betterment of this country. I have closely seen her spend sleepless nights bringing doctors across the nation together so that we can work and learn as a team and to fight this pandemic. This webinar was a need of the hour and would not have been possible without her hard work. Thank you so much, Dr. Bharti Kashyap, for getting very interactive session. And thank you, Dr.
Thank you, Dr. Beauty. And this webinar has not finished. The financial aspect and the great speakers of the session 2 are there. And we are going to start the second session. And we have the financial implication, financial part of our lives are very important. So we have 2 eminent national speakers today, and Dr. Merin Paul and Dr. Chitra Ramamurthy. While Dr. Merin Paul, a senior ophthalmologist owning a flourishing clinic, is going to give tips for successful running of single person owned small clinics. On the other hand, the Chitra Ramamurthy is going to enlighten young women doctors how to carve their career to achieve their goal. The magic she's going to teach you today, after her talk, each and every one of you would be convinced that sky is no limit. Great people are those who make others feel that they too can become great. Hence, the relevance of this second session of the webinar. And I would request Dr. Vibhuti Bhushan to introduce the esteemed women speakers. Over to Dr. Vibhuti Bhushan for introduction.
Can you see my slides?
Yes.
Yes. First, I would welcome Dr. Chitra Ramamurthy and a few words about her introduction. She is the medical director of the Eye Foundation, a chain of 10 eye hospitals in South India. She has been the chairman of Academic Research Committee, AIOS, from 2020 to 23. She had the special distinction of conducting a variety of innumerable instruction courses in cataract surgery, glaucoma, refractive surgery in both India and abroad, partaking in ASCRS, APAO, APACRS, and ESCRS on a regular basis. She has also many papers to her credit, both nationally and internationally, and has contributed to chapters in textbooks on refractive surgeries. She has held a number of posts in the past, past chairperson, Scientific Committee of Tamil Nadu Ophthalmic Association in the year 2002 and 2015. She is a management committee member of TNOA. She has got a number of awards. Just to name a few, she has received the Best Paper Award in the state and national levels, recipient of the TOS Ravi Kumar Reddy Oration Award in 2018, Dr. P.R. Mandal Memorial Oration Award in 2017 by OSWB, Dr. Om Prakash Gold Medal 2016, Dr. Vinod Arora Oration Award 2015, Dr. Subhash Agrawal Gold Medal in 2012 at different state and IIRSI conferences, Shiva Prasad Hadia Award for the Best Paper in Refractive Surgery in AIOS 2009, and CP Gupta Best Paper Award for the overall Best Paper at Tamil Nadu Ophthalmic Society. We welcome you, ma'am. Please accept a small bouquet of flowers from our side. Thank you for sparing your time, and we are eagerly waiting to listen to you. We have Dr. Marine Paul, another stalwart from the South. She has done her MS from MGIMS Sevagram. She is a DNB, FICO in cataract and phaco. She is a past president of Trichur Academy of Ophthalmology. She is a faculty at Kerala Ophthalmology Association annual meetings. She is a faculty at AIOS instruction courses, and she is a leadership development program alumni. And she has got a few awards also, Shankara Menon Award for the best paper. We welcome you, ma'am, Marine Paul, ma'am. And now I think we should straight away request Dr. Marine Paul to start her talk. The topic is survival tips for single person owned and manned small clinics. Over to you, ma'am.
We will take 10 seconds. We have prepared a small video. We will show. To show the finance is so important. It's just a humorous video, 10 seconds. Nitesh.
The whole thing with that, bhaiya sabse bada rupaiya. The whole thing with that, bhaiya sabse bada rupaiya. The whole thing with that, bhaiya sabse bada rupaiya.
So we all know the finance is very important for all of us. Without finance, at this moment, we can't even get a bed in the hospital. So over to Madam Dr. Marine Paul. She's brilliant. And I hope people have not left the webinar, because if they have left, they will be the loser. Okay, over to Dr. Marine Paul, Madam.
Thank you, Dr. Bharati. Can I start sharing my screen now?
Yes, ma'am, please.
So
Nobody
good evening.
Has left, everybody. Yeah.
So good evening, ladies and gentlemen, and thank you very much, Dr. Bharati and the Jharkhand Ophthalmology Society and IMA for having me here. It is indeed wonderful to, the first talk was so mesmerizing, because even though we feel that we know something about COVID, for us ophthalmologists, I think it was truly an eye-opener. Now, when I was first asked to talk on this subject, I was actually in a quandary, because this subject as it is a little difficult, because as Leo Tolstoy in his famous Anna Karenina first said, all happy families are alike, but every unhappy family is unhappy in its own way. Similarly, I feel all large or corporate hospitals are very similar in their SOPs, the way they manage their HR and PR activities. So they all basically have a basic template. But when it comes to small clinics, each individual clinic has its own unique USP or unique selling point. And to replicate this set of variables into another setting may not always be possible. But I would like to share my journey, and I will, and if this helps someone, I will be more than happy. So about 13 years back, I started my journey on starting a small clinic on my own. And I chose the logo with a lot of care because it should represent what I wanted out of the clinic. So obviously it represents the eye as the organ. It also represented me as a person and the eye generation. So the model that I looked at was a purely diagnostic setup. Now I do understand that there are others other than ophthalmologists here. So what I'm going to share is most likely to be helpful for not only ophthalmologists, but also for people who are surgeons. I do not know how much it is going to be helpful for medical people because the model cannot be replicated in that. Now, so when I say a diagnostic setup, I mean, we in ophthalmology need to have a lot of diagnostic equipment to come to a diagnosis. And we are, even though the eye is very small, we are divided into so many subspecialties. So once you do your fellowship and you come to a decision as to what you are going to do, like I am a cataract and phacosurgeon and a glaucoma specialist. So you need to invest in the machines which will help you to come to a diagnosis without having to refer the patient to a second center. Now, why did I go for this? The licensing for a small clinic is far, far easier than going for a big hospital setup. Now, when you have a big hospital setup, you need to go for all the fire and safety, the bio waste management, etc., etc. So all this requires umpteen licensing, and that itself can be a job of its own. So for a small clinic, all you need is to have a separate number and a electricity connection and at least about 400 square feet, and you're set to go. Now, the second pain point when you come to running an institution or any organization is the HR, or managing these people is a very, very difficult task. And I personally am very invested in how my patients perceive my clinic and the staff in it. So I personally train each and every one of them, and there is a particular way I like them to behave to the patients. So personal investment in time and energy to train these people is also a difficulty if you have a very large staff. And finally, of course, the major thing, like Dr. Bharti said, investment. Now, when you're talking about investment, I mean investment. There are two parts of investment as far as ophthalmology is concerned. We need to invest in our equipment and also in the clinic and the facilities that you're going to give in your clinic in terms of decor and other this thing. So those things we can reduce, or the investment can come down in terms of infrastructure and space if you are going for a smaller clinic. But I would definitely not advise you to scrounge on your equipment, because you need the best equipment to get the best results. Now, when it comes to the surgical setup, I have personally outsourced my surgical setups at multiple hospitals, but you can do it at a single hospital as well. Now, when you have a surgical setup in your hospital, it becomes actually a hospital and it's no longer a clinic. So the major problems which are associated with hospital running come from the OT and of course the income as well. So when you're outsourcing the surgical setup, you are definitely compromising a little bit on your income. But if you are smart and know how to negotiate with these hospital owners, you can, instead of saying that you will get a percentage of the bill that the hospital charges for the patient, you can actually hire the OT setup of the hospital for a fixed amount. Now that will of course depend on the facilities that the hospital has and the infrastructure that the hospital has. So now what I do is that I have patients who are higher end, who want premium lenses, who want premium services, and who may be wanting cashless or insurance, etc. Such patients, I take them to an NABH accredited hospital where it is a fully set up hospital with all facilities. Now, there are also patients who come to me who are of a poorer background, who are economically disadvantaged, and sometimes I do pro bono surgeries. So for these patients, I take them to a smaller trust hospital, which has all the basic amenities, but the fees are significantly lower. Now, before you start on this journey, you need to ask yourself why and how you do this. The first thing is that you need to know yourself as a person. What are your expectations out of this practice? What do you want out of life itself? And second thing that you need to understand is that you have to have a basic grasp of what your clientele will look like and what are their expectations of you and your practice. Now, when it comes to the issues that you have to consider about yourself, you have to think in terms of, is work-life balance important to me? If it is, then you can think of having a premium practice with low volumes. Then, you see only by appointments, you only see so many patients a day. Or if the money aspect is more important, you can definitely go in for a high volume, a lower pricing model where you will have plenty of patients, but your personal life can be grossly impacted. Now, the second thing that you need to understand is when you are sitting in a clinic for longer years, you develop a strong rapport with the community that you serve. Like I have patients now who I have seen as children now coming back to me with their kids. So this sort of gives me a lot of satisfaction, and it is more, so work does not become work, it is more fun. And finally, of course, a very important thing is the gender issues. What is your gender as a doctor will definitely impact on whether you want to consider starting this. So at every point, what a male doctor will want will be different from what a female doctor will be wanting out of their practice and out of their this thing. And of course, Dr. Chitra is going to elaborate on this much clearly, especially the financial aspects. But yes, gender definitely affects the choices that you make in life, especially when it comes to your practice options. But one thing you have to understand is that even if it is a small clinic, you just cannot start immediately after you have finished your fellowship or finished your post-graduation. It is very, very important that you need to get some experience under your belt before you start out on your own. This is because it is necessary not only to hone your skills theoretically, but also clinical, surgical, and most importantly, soft skills. How do you deal with patients? How do you deal with complications? How do you deal with communication with the patient? These are things that you need to, develop over time and hone them before you start your own thing, because then you're on your own. But in a bigger setup, you have much more support and much more, you'll have mentors around you to help you in difficult times. So when it comes to your patients, you have to understand the demographic of your area. You have to do a small survey kind of thing before you start out to see what kind of demographics are there in the area that you're planning to service. So if it is, say you're in a metro and there are a lot of young couples, it may be a good idea for a pediatric ophthalmologist or someone who has a lot of refractive practice to go and start a clinic in such an area. But if you are a cataract or a glaucoma surgeon, maybe a little towards the periphery, where you will have more of elderly patients who are more likely to approach you. Now, finally, it's another very important thing these days is marketing. Now, when it comes to marketing, there are multiple options. Traditional print, TV, media, of course, these are available. But when it comes to a small clinic, it may be borderline unethical to, do these kind of marketing. But definitely social media marketing is extremely easy and very plausible at very, very different levels. You can, your even different budgets can be allocated for this kind of marketing. So this is very important in today's crowded market, where you have to show that you are also a presence. Because when you're starting something new, or unless people know that you are there, it is very, very difficult to make an impact. Now, what are the disadvantages of having a small clinic? Now, first thing is that even though we say that there is a lot of flexibility, it is very, very difficult to take time off, because availability, that is the most important thing when you are in a small clinic. But it doesn't mean that you cannot take time off, but you need to plan properly and probably arrange for someone to take over for a short time when you are not there. So this extremely an important thing is that is the responsibility associated with this. Now, when I started out, I did not realize how much of administrative work is dependent on you when you start a clinic. You just cannot avoid it. So if you're not planning to do administrative work, you must have at least someone to help you with the finances, the auditing, and these kind of things. Even if you don't know about it, take time to learn about it and, have some idea about what goes into the planning of running a clinic. It's not just about seeing patients. And unless managed properly, revenue in terms like what you could get probably as a working for a corporate, the revenue may be lower. But like I said, if you're willing to put in hard work, there is no limit to the revenue that you can make. Now, another major disadvantage that I have felt was that as far as career growth is concerned, now, if you are interested in having positions in hierarchical structures, like, your specialty hierarchical structures, like we have the AIOS, or in our state, the KSOS, and so such organizations, then it is difficult for a smaller hospital owner or doctor working in a smaller hospital to do significant work in this, other than probably going into to distinguish yourself, to differentiate yourself. It is difficult. So that is something you need to consider. If you're interested really in academic and career growth, you should definitely go in for medical college service or something like that. So in summary, having a smaller hospital definitely gives you much greater control on your time and your working style. And even though you are, like I just said, you may not be able to grow much in your professional setup, there is a very great communities connect. And if your interests lie in the field of social work or politics or similar this thing, definitely I think a person with more grassroots connects to the community will do better than a person who's working in a corporate or medical college setup. And like I said, if it is not adequately managed, the revenue can be poorer and academic growth can be stunted. But finally, these are extremely personal choices, and personal satisfaction is the most important ingredient of any successful career. And that choice depends entirely on you. Thank you.
Very nice talk, Dr. Mary. And before taking the question answer session, I would like to take up the talk of Dr. Chitra Ramamurthy, and we would like to listen to our national leaders, Dr. Yashoda and Dr. Kavita Ravi, what they have to say after listening to two of you. And after that, we will take up the questions and conclude the session. So over to Dr. Chitra Ramamurthy. Over to you.
Just introducing her topic, she'll be talking about, should financial planning be different for a woman from a man?
Her talk is so good. Yeah. I kept it in the last to energize everyone so that they keep energized.
Just 1 minute.
Yes.
Both the leaders will come.
Yeah. First and foremost, am I audible?
Yes, yes.
So first and foremost, my very special thanks to Bharati Kashyap for so warmly inviting us and the entire Jharkhand Ophthalmic Society and the IMA. And I'm just going to tell you something simple and something which all of us can connect. So thanks, Bharati, for being so generous. And after hearing the earlier talk and the talk on COVID, I realized that I actually stand to gain a lot more by being a part of y'all. So the question which is here is, should financial planning be different for a woman against her male counterpart? Now we are all familiar, all cognizant with the fact that woman plays a very integral role in the framework of family. I don't think there's any doubt on that. And we also should remember that she's bright, intelligent, and she's very relevant to all the issues that clamor for attention at all time points. Meant to note that. What happens to her is, in the earlier part of her career, she's very much entrenched into education, growth. She thinks like the other male counterparts around her, and she thinks there is a beautiful, bright future open to her. And somewhere along the line, while her parents have been all the time very encouraging for her to be as ambitious as she could, therein comes this discussion of the matrimony. And of course, she being a sensible young ophthalmologist, she thinks yes, that has to be included in her life pattern. But then therein also comes a challenge of the indecisiveness of whether she does a fellowship, whether she should prioritize to start a family. Well, I think now in this present decade, all of us should press the pause button and give this a serious thought. Marriage, yes. Education, yes. But it's very important for this young woman to first go ahead and do a good fellowship, whatever she is capable of, and also combine with a fair amount of surgical prowess before she goes on to start a family. And it's absolutely an undebated point that this is how she should plan her priority. And then she should look at motherhood. There's absolutely no question that is the most precious part of her life. And it has to be a very decent, well-earned break. And she could take a break for a year or two because she has the background confidence that she can pick up the threads as and when she needs. It doesn't mean that was the only crossroad which she had to face. She's eternally bridging bridges between the family, children, and there's also that career pull which is always there. And she's also connected in the social media and with her friends and her contemporaries, and she keeps remembering that she needs to stay afloat. Now, this was a particular survey which was done, and the global pattern of women, how it is that a woman spends on an average 352 minutes a day on unpaid work as against 52 minutes among men. So this has to be kept in mind. But this goes on with the way she's working. But then a time also comes when the scenario is going to evolve, like the children are growing, are grown up, and a moment of redundancy should not set in. And it should not become that late a moment of self-realization when she awakens to the fact that her lifetime ambitions have not been realized. Friends, we only see obstacles when we take our eyes off the goal. In other words, what I'm trying to say is she has to set a foundation for an ever-evolving growth in small quotients, because she should not be caught into an unnecessary hurdle race where she's absolutely not qualified and outdated. So it becomes, it's now, don't think that while I was talking about motherhood at one extreme, and I'm then telling you again that she has to take in small measures, because it is so important that she remains relevant to her profession. And maybe she could take shorter working hours those initial few years, but she has to ensure that there is quality inherent. She should not end up in a place which is going to stunt her and not allow her to evolve, or does not have a promise of a growth which she's looking at. So growth has to be a constant process. It would have its gradient. It would be a slow, steady climb, but she has to remember that career is her personal belonging, and it will grow only as much as she allows it to grow. In other words, she has to have a constant questioning mind. She cannot let things to happen on their own. She cannot waste her energy or get rebellious or get militant with the other newer family she's gone into. There has to be a constant urge in her to grow and be prepared for the stumbles along the way. And mind you, even if she's in the most loved family, she has to realize that this is a solitary climb which she has to plan for herself. While all this is happening, there are different surveys she comes across where she gets to know that the Indian women are earning only 19%, 19% less than their male counterparts. These are not the issues which she is going to be addressing. because it's the need of the hour for her to define herself, to consistently redefine herself as she's evolving, because she has one goal post and the next goal post to achieve. So there are business models galore, as was alluded to by Merin Paul earlier. But woman has to understand that rather than being just rungs of ladder for others to build their success stories, shouldn't she have enough courage to dream a pinnacle for herself? So then comes the very essence of the topic. What would be the business model for this late starter? And this is a question which she has to keep asking her again and again, which means at every turn, she has to equip herself. She has to learn some surgeries, go for short-term fellowships, qualify all those small qualifications, which is going to help her further ahead in life while she's doing work in a slower measure. She has to knock every possible door to ensure that some form of surgical improvement is constantly happening to her, because friends, only then you could even dream of a level playing field coming in later in your life. While all this is also being happening, she needs to build an army with intelligence and passion. In other words, every single family member of her becomes a brand ambassador for her. It's for her future gains. They are her backup plan. They are her safeguard. So what I'm trying to tell, she needs to strategize all those very important internal relationships and not think nuclear, because that's the only way you are going to be a winner faster. There is absolutely no sense to win those small, trivial points, because you have a bigger, beautiful battle ahead, a stronger battle, and you have to be victorious at the end of it. So don't lose sight of your final goal in question. So then you need to differentiate yourself from all those routine negativism, which is seen in women. You need to strengthen that inner psyche of yours. But again, you need to sustain the generosity and the grace which a woman has and which a woman needs to give to her family and society. But at the same time, perceive that goal, and it is a reachable horizon, dear friends. You need to acquire the management skills, whatever gets thrown in your surrounds. You have to make it your point to understand finances, basic finances, and a little more. In other words, there has to be an ever-increasing thirst. You might find yourself in different job profiles. You have to understand the nitty-gritty of those profiles. How is the front desk handled? How is the reception handled? How is the accounts handled? How is the opticals handled? How is the pharmacy handled? How is the theater handled? You need to formulate your thought process earlier on in your career, and you need to be very sure. You have managed a new home at a very young age. Why can't you do something even more challenging? While all this growth is happening, you should ensure that you get some podium presence. You have to acquire skill sets. You have to be abreast of the newer technologies. You have to be abreast of the evolving science. You have to constantly remain academic relevant. And this is very much possible today, dear friends. And in this process also continuously evolve to become a more stable surgeon, and the growth has to be continuous. You actually need to self-assess yourself every now and then, rather than lapsing into a state of foolish confidence. You probably need to maintain a mental diary if you have a different strategy or growth for yourself. Sometimes mentors also come as a bonus, but you need to be sure that this mentor of yours has a very positive outlook to life. This is another survey which said, are women less capable or less ambitious than male counterparts? And this survey said that the post-op surgical outcomes are actually slightly better for female surgeons. Well, I wouldn't want you to interpret this as saying that women are better surgeons, but at least let it debunk the myth that women make worse surgeons. So then you need to look at the models which have to be discussed now. Now, do you perceive yourself in a solo small venture? If it is an underserved area and you feel that you could even easily click if you are looking at a solo practice, you could get attached to a nearby well-facilitated hospital or more, as was so beautifully discussed by my earlier speaker. Or if it is a larger city or a township, then you could think of joining a group practice where you may initially be a younger partner, but you could build and let that all that group all those in this group practice to understand that you are on a mission in life, that you have your skill sets, and you are definitely going to give strength to that group practice. And they could rely on her, which means she needs to work harder than all those male counterparts she has in her group practice. She could even contemplate a government setup, but it should not be a primary health setup kind of a place or a languishing government setup. She needs to look at a government setup which would enhance her future if she's going to go into a private practice or go into a corporate base. And corporate bases are now there everywhere. She could perceive them as her step ladder. What is most important for her is to build a name in her immediate practice from the time she has started a practice. She has to get known in that patient community as a good surgeon, as a complacent, friendly person. She needs to even start collecting her resources, find out about bank loans if she's planning to start a private practice, get attached to a very stable, smaller hospital. She has to market herself at all times. Probably she could even find a social niche for her to gain a prominence at a faster level and keep on evolving. If she has a philanthropic husband to help her, then the things get even easier. But if this small boat or this small practice appears rocky and sort of not sure, then don't board it. You start climbing the stairs with your senior practice partners in your group practice or in a corporate base. Make yourself indispensable to them. Wherever you are, is it a standalone big hospital or a corporate chain, you establish your stand, work tirelessly, make these senior partners get a sense of permanency, that you're going to be with them, that you're going to grow with them, and they would allow you to grow, gain prominence. A time will come, I promise you, that you will start having a share in that small business, and there would be an incentivized growth, and that would actually be a risk-free life. You actually need to have a sense of ownership and pride in yourself. And if your husband practices is what you're joining, I tell you, friends, sky is the limit. You could become his right hand, you can become his left hand, you could become his dream, you could follow the leader, because he would take care of you as he evolves. And don't get into that competition or ego clashes or rivalry with him, because someone has to be a leader, and the person who follows the leader also has a winning post right ahead of them. And keep all your family ties with you. Never lose sight of that army which you as a woman would need, because you would need them at different time points when you're going to move away from family for your short stints. Women are foolish to pretend that they are equal to men. In fact, they are far superior and have always been. And if you want, ask a woman, because if you want something done, you ask a woman. I'm sorry. So friends, this woman, you see, this young woman is a winner. You watch her, you don't challenge her, because she has challenged herself at various segments in her life. She's got the best of all her inimical moments. She has made new families, her own family. She has risen up slowly towards a pinnacle, maybe later than you, but she has had her most cherished moments. She has taken diverse paths. She has been a housewife, a housekeeper, a cook. She's a versatile woman. She's a man in a man's world, a woman in a woman's world. She's an unbeaten second half, probably a better half. I tell you, woman, it is what you want to be, is what you will be. I hold back in discussing a separate financial plan for this woman in question. It is not the financial model which limits this woman. It's her sense of holding a major share in her family evolution, ensuring that her family has safe surrounds and the great strength which she gets therein. I think we should say kudos to all these evolving women. And I wish every woman to stay happy with the choice she has made in her life. They say that when you educate a man, you have educated an individual. But when you educate a woman, you have in fact educated a family. Thank you.
Thank you so much. Thank you, Dr. Chitra, for your wonderful talk. And after the talk of these two dynamic women leaders, we would like to from national leaders over to Dr. Ali Yashodha, our national president. Madam, over to you.
Thank you,
Yeah, I
Dr.
request Dr. Bharati. I request all of you who are not speaking to kindly mute your kindly mute yourselves. Yeah.
Okay, madam. We are eager to see listen to you.
Thank you, ma'am. I'm so happy today. I should say a big thanks to Dr. Bharati for inviting me for this occasion. Very nice seminar. Congratulations to your whole team and your young ophthalmologists. As you are also young ophthalmologists. You are the role model for all of them. And thanks to your president, secretary, and treasurer. You're as usual. You're so lively and very bubbly. Dr. Bharati, I think you should do more and more programs like this. All the topics, which for today, mostly the ophthalmologist is very useful during this period of COVID, because we see a lot of patients now starting from conjunctivitis during this period, more than fever and cough also. And the topic which you are the earlier speaker, now Dr. Chitra Ramuti spoke about finance as a woman, and me being in the women doctors wing, I feel both men and women, the notes and rupees are same, but we face the same problem as both. As men face the same thing women faces. But economically and to get the budget properly preparing, a woman does better than a man. That's what I feel. Which I wanted to say to Dr. Bharati. And Madam said there will be a gap. Like you are pregnant, you have to take a gap of 1 year. Till that woman comes back and she compensates that 1 year, even during the prenatal or postnatal, during that period also she thinks about our hospital. She tries to manage it, except that 40 days, that labor period and whatever it is during that time. After that, she again comes back and nicely fills our financial problems also. And she also advises also at that time to the husband and the home. And I feel more than a doctor, we actually play more role of all artists. Like as Madam said, mother, sister, brother, everything, and not even more than a doctor. We to the society also. We help them. Sometimes when they have a financial problem, like see, even if during the corona period, I do remember last year when our servant maids all were suffering, where our hospital staff all were suffering, but still we fulfilled their financial budget. I do remember most of the doctors I know, even if they had their food in the house, enough food or better, they've helped the women people, women society, because there are the people who work for us loyally, and we also try to help them financially also during that time also. And away from this, I normally say, women in between a group or in any function, like we are preparing a CME. I do remember now Dr. Bharti, almost 1 month she's been behind this CME webinar making. See, she's a great woman. She has done it. And she has done it so well and true. And why means we actually first think about the finance only. See, when you're conducting a conference and this, we like to get the conference very truthfully fulfilled. So we first think where to go for the finance, how to make the program successful, how to make the program very healthy. So that financial thinking, how to adjust, I think the women doctors do well. That's what I feel. So I think even the men doctors do agree. But those people, they will be thinking about the topic, speakers, all that. We think about the finance behind that because we have to run the show, isn't it? I think Dr. Bharti, you will say yes to this. And whatever the madam said, how to run in a clinic and hospital, I think we have to think that properly and do it so that we don't get into any further, like, see, the more worries also is for a woman only. We will be thinking that we have to fill the whatever loans we have got, that we have to finish all this. We have to properly adjust, and to the mark, we have to actually go along with the society. So I once again thank Dr. Bharti for giving me this occasion. I'm so happy and seeing you through this virtual media. Hope so, by God's grace, one day we will see in person. Best of luck, ma'am. Thank you so much.
So thank you so much, madam. And we hope that in future also you will be a part of us, because it is in a near future, I am going to plan a awareness program with 30,000 sanitation worker, Jal Sahyas, on the webinar itself. So we would like to have you again. And I'm really thankful to our women speakers, Dr. Mary Paul and Dr. Chitra Ramamurthy. And now over to, please stay with us, because these two leaders are going to talk about you only, Dr. Marina and Dr. Chitra. So over to Dr. Kavita Ravi. She is our secretary, National Women Doctors Wing Chapter. Over to Dr. Kavita Ravi, madam.
Yes. Thank you, ma'am. Respected WW Chairperson of Jharkhand, Dr. Bharti Kashyap, all the other office bearers of Women Doctors Wing, the IMA state leaders, and the speakers for today. So at the outset, let me thank Bharti ma'am for giving me this opportunity to be a part of such a wonderful CME. So I've been here from the beginning. I put off the video for some time because I had some other meeting also, just to attend. But see, it was really very informative session, and it's indeed the need of the hour. This pandemic scenario going on in our country. You know, in Kerala also the situation is getting worse, and so it is useful to every day updating our knowledge on COVID. And for me, it is a personal thing too, because I am also a COVID survivor. And as Sir said, I have been suffering for long, one of the long haulers, as he rightly said. I had so much of post-COVID symptoms. I am just recovering from it. And I know, Dr. Bharti, you were also suffering from COVID. And I'm so happy that in spite of being sick, you were doing all the women doctors wing activities also. And after that wonderful informative talk by Dr. Ravi Kashyap, I'm really amazed, listening to Dr. Miran and Dr. Chitra. See, actually, I was thinking right now, it's mere coincidence that I am now working in the ophthalmic wing of Government Medical College, Trivandrum, because we have a post of pathologist there. So by rotation, we go there. And now I am in the ophthalmic hospital. So I was thinking that both Chitra madams as well as Merin madams talk, So the residents there, the junior residents as well as the senior residents, they should they must listen. So because it's so useful for them to start their career. So anyway, I'll be mentioning to them about you both. And see, much have been spoken about women's capacities, etc., etc. But let me tell you, Bharti Kashyap, Dr. Bharti Kashyap, as I am quoting Yashoda madam again, I'm repeating, she is a wonderful lady, a role model for everyone. Because I am seeing her reports for quite some time, for the last 2-3 months. So much work on all the projects of Women Doctors Wing, especially cervical cancer eradication and organ donation. So being part of the Jharkhand Ophthalmic Society, you are having you are doing maximum contribution to the corneal transplant and eye donation. So congratulations, Dr. Bharti and the Jharkhand Ophthalmic Society for being so active. And another sad thing I want to share is so many beautiful and efficient ladies are here today on this platform, but I don't know any one of you. I'm so sad, being the national secretary, I really feel sad because I don't have your contact numbers. I have never talked to you, but it's not this situation in many other states. I do have personal contact with all the leaders. I don't know why I don't have your contact. And I have the contact number of the secretary. Dr. Prabha Rani. I'm so many times I've sent text messages, voice messages, mails, but no reply from her. So, like, it's my humble request that we both, Yashoda ma'am and myself, we would like to keep contact with all the WDW leaders in all our states. So please, get my number and madam's number, or at least my number, so that I can give your number to Yashoda madam. So please, at least send a hi to me, and so then I'll keep your number or add you to our WhatsApp groups, our mail groups, so that you will also know what is going around in our in WDW across the nation. Because I see I'm listening to all of you, like how you speak, how you present yourself. So then why you are hiding, or why I couldn't meet you? So that is my I really maybe it's my problem, I don't know. But anyway, from today onwards we'll keep in touch, because WDW is becoming very Women Doctors Wing is becoming very active in all the states. And now I feel it's a one-man army, one woman army in Jharkhand. So please join with Dr. Bharati Kashyap and take the Women Doctors Wing of Jharkhand to greater heights. So congratulations once again to the entire team of IMA Jharkhand, Women Doctors Wing Jharkhand, Jharkhand Ophthalmic Society, and especially to the great speakers, Dr. Lily Kashyap. And again, I use the word especially. I am so proud listening to Dr. Merin and Dr. Chitra. So thank you all. Thank you very much.
Madam, thank you so much. In fact, you have inspired me in a way. Like when I came back from the hospital, I was hospitalized for 10 days in the month of March. So I had an activity report before COVID attacked me. Actually, I was thinking that I'm having typhoid, but I was having COVID. I went and gave an inspirational speech on International Women's Day and sent it to you. And then when I told you that I was hospitalized, then the next day I was seeing the messages, please send the reports, please send the reports. Then it really inspired me. And Dr. Chitra Ramurthy's one line that women doctor, you only see obstacles when you have your eyes off the goal. When your eyes are focused on the goal, you don't see obstacles. So when I was recovering, at that time only I planned this webinar. And I'm really thankful that it worked well. And later on, I added Dr. Merin and Dr. Chitra when I heard them recently in our AIOS webinar. So I have sent all the contact numbers to Madam, because Madam always asks reports from all the districts. And so I have created chapters in each and every district of Jharkhand. And I sent the mobile number, email ID of each and every office bearer, so that she can be in direct contact with each of one of them. So now I am summing up the session. So ultimately, what Dr. Chitra Ramamurthy has presented and Dr. Merin Paul has presented, ultimately our decision in life, the women doctors, revolves around few factors: money, how much money we have, how much space we have, how much, what is our family setting, and all our passion and attitude, what we want to have in our life. More, we want to do more service for the community, the way I did, and you want to earn huge money, the path my husband chose, or the path many of them they chose. So if a young female doctor wants to be very successful as a surgeon, this I have taken from Dr. Chitra Ramurthy's talk. She must complete her fellowship and acquire all the surgical acumen needed to be a successful surgeon before starting a family. And it is true that only a woman can build a bridge between profession, family, and children. The most important take-home message, what I felt as a woman doctor, is you only see obstacles when you take your eyes off the goal. If your eyes are fixed on the goal, even if you are recovering from COVID, you can do it. So now, on behalf of Jharkhand Ophthalmological Society and Women Doctors Wing, IMA Jharkhand, I thank all of you, our national leaders, our speakers, our two great women speakers, Dr. Ravi Kashyap, everyone. I thank for sparing their time, and I hope that you will be with us whenever we need you. Our national leaders, our Marine Paul, our Chitra Ramurthy, they all are very good speakers. So thank you all. Dr. Vibhuti, you have to say something. Our president, Dr. Lalit Jain, sir, you want to say something? What did you feel about the webinar today? He's our president, Jharkhand Ophthalmological Society.
It was an excellent show. Very good. We learnt a lot.
Our young ophthalmologist, Dr. Mala Divedi, I can see. So did you learn the Marine Talks talk was for the young doctors like you who own a single person manned clinic. So did you gain anything, Dr. Mala?
Yes, ma'am. Nice program. I think we gain a lot of that COVID program. Also, Chitra ma'am's
program was for women doctors. तुमने क्या सीखा आज अपने क्लिनिक को एकदम अच्छा करने के लिए?
मैम that's वही तो मैं बोल रहा हूँ. चित्रा's ma'am presentation shows not only women's, it's also for men's to focus on our goals, and we should revive for our program. We should go for small skill programs so that we can improve ourselves. This is also for young ophthalmologists, also useful for young ophthalmologists also.
So this program was focused for young ophthalmologists, young women doctors, young doctors, because everybody, so many of them, they are having small clinic. So not all join the corporate. Dr. Beauty, you have to say something.
Unmute yourself, Beauty. We can't hear you.
You're not here.
Yeah.
No, she's there.
Yeah.
I can see her.
Yeah, I am here. You can hear me now?
Yes.
Yes.
Yeah. I gained actually a lot of knowledge through this session. First, Dr. Ravi Kashyap. He was so elaborate in all the things, starting from the RT-PCR to the actual value of the CT value. Then about the rat test, antibody test, about vaccination, about the RT-PCR and the way people are running after remdesivir and this plasma therapy nowadays. So the plasma therapy is actually not of very use.
It is only for immunocompromised people who are admitted.
Yes, and there is so much drive for this plasma donation and things. People are giving so much energy and time in this plasma thing. So he actually told us about a lot of myths and the unnecessary treatment we were giving to the patients.
So your clinic is also one person owned. So how did you like?
Yes. I liked. I was coming to that. For that thing, I gained a lot. And now I know what to do and what not to do for my one-person clinic.
And Dr. Chitra, I can't
Thank
see.
You, Doctor. Thank you, Dr. Marine. Thank you so much, Dr. Chitra. Thank you.
So, okay.
And Dr. Kavita.
Now the time to have a bye-bye till we meet again.
Thank you so much.
Thank you. Time. All the national leaders, all the speakers.
Thank you, Doctor.
Dr. Ravi Kashyap had to go because he's
he's not here. Okay.
He's director of Methodist, and this is the morning time. He has to rush to the hospital because all of the people the hospital is flooded with COVID patients.
Thank you, Dr. Kavita Ravi.
Okay, bye.
Thank you so much. Thank you so much, Dr. Bharti, and thanks everybody. It was nice meeting all of you. Thank you.
Bye.
Bye. Good night.
Thank you very much.
Good night, everyone. Thank you once again.
चलो ओके चलो विभूति सब अच्छे से
चलो,
हो गया
सब